Welcome to the Moulding Health Show. Our goal is to leverage the wisdom and experience of healthcare practitioners to set you on a path of self-discovery and healing. These insights, coupled with a multidisciplinary approach to each area of interest, should provide an invaluable resource to everyone looking for a better approach to health. In this episode of the show, we speak to Samantha Harding about antenatal and postnatal care from a physiotherapist perspective. Samantha Harding, welcome to the show. Thanks so much for being on the show and for spending your time with us.
Thank you very much for inviting me, Oliver.
So we normally get it scheduled by the team, but for this particular one, you came very strongly recommended by one of our previous guests, Shelley Hall. So I think Shelley mentioned your name, and we reached out. So it's always nice, seeing how the connections happen, because for many people, like you included, we've never chatted before, but it's interesting once we get on a Zoom call, like how the conversation just kind of flows. But yeah, very cool to meet you.
Yeah, I was very glad to be given this opportunity. It's a nice platform to educate people about what there is out there. It's a newish field in physiotherapy, and very few people know the value in it. So I'm glad that I've had the opportunity now to talk about it.
Yeah, no, I'm really looking forward to the conversation, because as I was telling you just before the show, or before we started, is for postpartum depression, I didn't realize it is as big as it is. And, as you pointed out as well, whenever you think of it, you always think of it from a therapist, like a mental perspective, but there's so many different aspects to it. We had the social worker, Sally Baker, on, and we had Rueda Muller from a midwife perspective. And then obviously Shelley came on from a clin psych point of view. But yeah, talking about postpartum depression from a therapist perspective. So I'm really, really interested to break it down. But before we kick off, I know we covered it in other shows, but just for the interest of the audience, what is postpartum depression?
So Oliver, I'm going to be talking more on antenatal and postnatal, postpartum care, and as a physiotherapist, that's more the physical aspects of what can happen with the body while you're pregnant, what can happen with the body afterwards. So while it's important for us to recognize signs of someone who might be struggling with depression and then refer very early on within the team, I'm specifically, my role is more within the pelvic floor. So it is, I guess, as we start chatting and you ask questions, you might understand where the physio fits in. As I said, it's a very unknown field. So hopefully you will also understand. So I don't really know the specific definition of postpartum depression, because I don't treat it. I just need to know to refer it.
Okay, cool. Well said. And and thanks so much for clarifying that. So then if we think about antenatal and postnatal care, obviously it has something to do with, pregnancy, but is there particular reasons that a client would normally start seeing you then? Is it a referral from someone else, or is that something that they would immediately put, the two together as, I need, I'm experiencing this, so I need to go speak to Samantha?
That's a good question. In theory, a client can come straight to us if they're experiencing any of the issues that we work with. They don't need to have a referral. But because so few people know what we can help with, a lot of people end up coming much later when it's more complicated, and it's sad to watch that, because some stuff is so preventable and it's easier to have a better outcome, obviously, the earlier you tackle a problem. But definitely your gynecologist is also a place where we get referrals from, or your GP. Again, if they know the value and that it's something that we can treat. So that's one of the biggest reasons I'm actually quite excited about talking about it, just to get the word out there.
Okay, cool. So when a gynecologist normally refers, is it a certain time within the pregnancy that they normally refer the patient to you?
So it depends on the problem, I guess. So yeah, I guess with one of the things that we see a lot of is pain, so lower back pain, sciatica, pelvic girdle pain, and it is more common in the later stages of the pregnancy. But someone who's potentially suffered from back pain prior to being pregnant is obviously higher risk of having that as a problem during pregnancy, and they might be referred earlier if that's when their symptoms start. So yeah, and then I guess the other role that we play is more prevention. So exercise, antenatal exercise has lots of benefits in preventing disease. So in that sense, it would more be, I guess, the mother either joining some type of antenatal exercise class or coming in to find out what can they do when they're pregnant. Yeah, and a gynae might refer if a lady is struggling with incontinence during pregnancy. 30 to 55% of ladies do struggle with stress urinary incontinence during pregnancy, but also normally in the later phases when there's more load on their pelvic floor. So that would also possibly be a referral during their pregnancy. Benefits to exercise are vast. And to name a few of them, it would be decreased risk for gestational diabetes during pregnancy, decreased risk to gaining too much weight during pregnancy, a decreased risk for preeclampsia, decreased risk for suffering from any painful condition, because there's a hormone relaxin that develops during pregnancy or that's secreted during pregnancy that basically allows everything to stretch. So you've got more movement within the bones. Your passive stability from your ligaments are not really there so much. So to compensate for that, your muscles are very important. So if you've been strengthening throughout, you've got much less chance to get something like SIJ pain or pelvic girdle pain throughout pregnancy. It decreases your risk for morning sickness, for maternal fatigue and exhaustion. It improves your energy levels, decreases risk for postnatal depression. So lots of benefits to starting to exercise. Hopefully you were active before pregnancy, but to not give it up, to exercise throughout.
Yeah, I mean, I always love it when dietitians and physios are on, because you make it sound so easy, and like you should just be healthy and exercise, and and then the real world happens, and like people like are not, and, but it's
it's a concerted effort to stay active, I think.
It's definitely a mindset thing, eh? I mean, I covered this, quite a few practitioners, because it sounds so easy, just do 20 to 30 minutes. I think that's what, some of the health insurance companies like Discovery mention. But yet, as human beings, we find it so difficult to do that, like carve out like half an hour. And I know that's more mental thing and, as you said, a priority thing. But it's interesting.
Yeah. If you commit half an hour to exercise, you've still got 23 and a half hours for everything else in the day, but it's still difficult.
And it sounds so easy. I mean, it sounds so easy. Like, say, even meditation, people say you do 5 minutes a day, and, it's amazing because it, like resets the brain patterns and stuff like that. But just finding that, it seems like it's almost like a impossibility, especially with, family and kids and work and everything else. But I'm glad you mentioned that, because I think it's part of a overall, good well-being. And I think, and this would be almost like the intentional part of like getting pregnant and, knowing that, something is, like it's obviously going to be a big change from your self perspective. We've got 2 children, so watching my wife go through it was interesting. But I think, and as you said as well, it's like, your body is changing so much. that it's interesting also to know what is normal and what's not normal, because you mentioned lower back pain, but she definitely struggled with lower back pain, and we just thought it's part of the pregnancy.
It's common. It doesn't mean you have to struggle with it though. And some people are lucky. They'll have an issue with pregnancy and afterwards they recover on their own. But other people struggle, forever, or for long periods of time. And that's where prevention is nicer, or to at least know when something is a problem to get help early.
Okay. Another one that caught my attention was when you said it decreases morning sickness, because I think with my wife, she struggled with morning sickness. So I'm interested to see how would that have helped? How would the exercises have helped?
I know that it increases your rate of digestion as well. So I wonder if that's maybe the connection. But I'm not 100% sure the mechanism. I know there's tons of benefits to exercising. Obviously, you want to have the go-ahead by your gynecologist. If it's a very complicated pregnancy, you might you might not be allowed to exercise, and then that is what it is. Exercise works in many, many, many different ways, and I suspect maybe with morning sickness, it's got to do with the digestion.
That kind of makes sense, and I think she had lots of reflux. I think that was the one thing. I know when Rueda was on, she mentioned, you could take supplements as an example, and that helped with the morning sickness, which I thought would have been interesting. We did take some of it, like the gynecologist obviously recommended, like, I'm going to be wrong if I say it, but probably like folic acid and stuff like that. But so there was quite a few vitamins that she had to take, but she still struggled, through that. So we covered a few things so far, but just going back to like the first part, maybe is talking about common problems. From what you mentioned now, is there anything else that a patient would normally seek out help for?
In the antenatal phase, it's basically what I've spoken about. Commonly would be pain in the lower back or the pelvic area, and then potentially stress urinary incontinence. But with the postnatal phase, there's if you've been struggling with pain during pregnancy, you can obviously still have it afterwards, and the same with incontinence. But you could also have signs of prolapse. So about 35% of ladies struggle with symptoms of prolapse, which can often be described as a dragging feeling that worsens at the end of the day. And then another common one is pain with sex. 3 to 4 ladies have pain with sex after pregnancy, and not all of them come right with time. And then 35 to 39% of ladies also struggle persistently with a condition called diastasis rectus, which is where the abdominals, if you think of your six-pack, where that line is in the middle where they pull apart, and it's normal during pregnancy, but it's supposed to go back together. And for some people that doesn't go back together. And we can give treatment strategies for that as well.
Would that require surgery? I asked that because, or does it come back on its own?
Sometimes, yeah. If it's about 4 finger widths, 3 to 4, then you're looking potentially at it having to be surgically repaired. If it's only about 2 fingers, then often conservative management is successful.
Okay, that's interesting. Okay, that sounds, and in terms of the exercises, Samantha, is like, so do you take your patients through like a program? So once you've determined, okay, well, what is it? Then is it like a regular program, and is it something that's more ongoing, or is it like, 3 or 4 month program, and, you basically see how it goes from there?
If someone comes in with pelvic girdle pain, or lower back pain, then your exercises would be specific for treating that. So with pelvic girdle pain, for example, you would avoid any exercise where you take your leg out to the side, and you would give movement strategies. So one of them would be to kind of pretend you're wearing a very short skirt with no panties. That's kind of how you need to move when you've got that type of pain with pregnancy. So exercises will also be with that type of thing in mind until we get the pain down. But a lot of the strengthening is around the pelvis to give that stability, because that's normally what's lacking and giving a lot of pain. When we're looking at the other problems within the pelvis, if I can maybe explain to you what the pelvic floor is. It's a group of muscles inside the pelvis that forms like a hammock shape, and it connects in the front to the pubic bone and then to the tailbone, and then from side to side to your sit bones. And it's the bottom of our core. So we always think of the abs as our core, and then there's some muscles at the back, multifidi, that are the back, but the bottom of our core is our pelvic floor, and the top is our diaphragm. And the pelvic floor during pregnancy obviously has a lot of load put on it throughout the pregnancy. And then with giving birth, if you're giving vaginal birth, it stretches between 2 to 4 times its normal resting length. So even if you don't have an episiotomy or a tear in the perineum, it's still quite a lot of trauma that your pelvic floor goes through. And your whole posture changes during pregnancy as well. So if you think of a lady in her 3rd trimester, her center of gravity has changed. Her stomach is gotten so big that her shoulders are kind of leaned back behind her hips. Her weight bearing is on her ankles, on her heels. And when she's given birth, what we talk about as the kind of incontinent lady posture is developed very much because of these changes that your body goes through during pregnancy. So your lower abdominal muscles have stretched out, and so is your pelvic floor, and they don't just bounce back. So your top abdominal muscles are normally quite tight because you've used them for balance and to move during the pregnancy. So they kind of grip at the top. And often ladies will have a little bit of a pouch at the bottom of their belly, and that's kind of because of this pressure from the top and this weakness at the bottom. And their bum disappears, so they normally have a bit of a Pink Panther posture. They're a little bit back with no bum, and that's typically what we would describe as the incontinent lady's posture. And a big reason is because in that posture you've got you can't breathe properly, so we're not getting diaphragmatic breathing, and there's also not good control of pressures within the pelvis. So in that sense, exercise would be to improve their posture. So you would do a lot of glute strengthening, you would release the tight abdominals, you'd work on getting the lower ones working, and you would engage the pelvic floor as well. And yeah, that's how we would maybe target incontinence and exercise in that. And then with the prolapse, it's also quite fascinating because there's some new research on it now. So if you imagine that the hammock of the pelvic floor is a trampoline, and your organ, say it's your bladder that we're talking about that's prolapsed, is like a balloon on top of the trampoline, then whenever you cough or sneeze or bear down, there should be a give in the trampoline that supports that balloon or that bladder, so that there's not so much load on the bladder. And what happens is sometimes, because most of us actually have tight pelvic floors, if there's thick scarring from maybe an episiotomy and scarring within the pelvic floor, if you've had quite a traumatic birth, and just tight muscles that are in spasm. And then instead of a trampoline, you're looking maybe at like a sheet of metal. And now this poor balloon, whenever you're coughing or picking up your baby, there's this squash on this vulnerable structure, and you're getting quite a bit of pressure put on that. And so the new theory is that if a pelvic floor physiotherapist releases that tight pelvic floor and those tight scar tissues, that we're getting back that give and that trampoline effect. And then what can happen is the prolapse itself can physically look smaller, and the symptoms of the prolapse can also ease. So it's quite exciting, the new research that's going into that. And obviously, once you've released a tight pelvic floor, you do want to start to strengthen it, so get that control where the muscle is working through its full range properly. And teaching someone who, even if they've got a tiny prolapse, how to maintain good pressure. So you don't want someone who's got signs of a prolapse to struggle with constipation. So then you might do good toileting habits and things like that to kind of limit the pressure unnecessarily on the prolapsing organ.
Okay, that sounds amazing. I mean, I learn all of these new words and like into my vocabulary, but I mean, like I would have never heard prolapse before. And I mean, so do clients actually come in and say, I have like an issue with prolapse, or is it another term that they use, or do they just have the feeling? Or
yeah, so if the gynae refers them, then the gynae will tell them that they've got a prolapse, and they'll come in and say that that's what they've got. Otherwise, we kind of recommend maybe a 6 to 8 week follow-up after you've given birth at a pelvic health physio. And then when you do an internal examination of the pelvic floor, then you might find that there's a physical sign of a prolapse, so maybe bulging in the front wall of the vagina, that when they do a cough, you feel it bulges more, and the mother might also be describing symptoms of a prolapse. So they might be saying that they've got this like really uncomfortable dragging feeling, and it's worse at the end of the day, things like that. So yeah, both ways. But no, often a mom won't come in if she doesn't know that it's a prolapse and say, I have one.
Yeah, I know. I mean, I think that's one of the huge benefits of doing the show is like, almost like we always say, like, when you go onto Google, what would you put in? And I mean, like in my mind, before today, before 2 hours ago, I would have never put in prolapse, but it's interesting hearing you talk about it, and the dragging. I mean, that kind of makes sense. And I think anyone going through it then, what's interesting is if they heard this, they would actually put that together and say, okay. And then it takes you down like it's like the door opens and then kind of says, okay, cool. Now I know what to, search for, which is cool. I'm glad you mentioned the research as well. I mean, I think that's the amazing thing about the world is that we're getting to learn so much more. And I think probably like 50 years ago, women would have just struggled through this, or just, no one would understand it. But by having like amazing people like yourself, at least there's like a resource that they can go to or learn from. It's amazing. And in all of my time, I mean, we worked with many healthcare practitioners, but I don't think there have been many, around specializing around the pelvic floor, or maybe we haven't come across them,
Yeah, it is a niche, it's a niche field. So it's growing because we're learning that you can't just treat low back pain if you know nothing about the pelvis. So it is growing as people kind of see that it's part of the body, and so you can't ignore it. But certainly, women, I mean, you say that women have all these resources that they didn't have before, but I think what's sad is that so many women don't know that they've actually got access to it. So if we look at just how common dyspareunia or pain with intercourse is after birth, I mean, 3 out of 4 women is a lot. and they're not talking about it. It's sad because often you'll see someone years later and it started straight after birth, and like now it's more complicated because now there's your central nervous system that's involved. Now you've got anxiety, thinking about having intercourse, so it's become much more complex than potentially a thick, painful episiotomy scar that needed to be loosened, to resolve the issue in the beginning. So, I'm glad it's getting out there. People are learning about it, but it's still something that a lot of people don't know that they have the resource to.
I mean, that's amazing. And also, thanks for mentioning it, because I mean, it's such a, I suppose, sensitive topic. Maybe that's part of the reason why no one, because who would you speak to that about? I mean, would you speak to about
they think they're on their own.
Yeah, exactly.
Meanwhile, most of your friends had it as well.
Yeah.
But they think they're on their own.
Okay, cool. Yeah, and just mentioning that stat, like you said, then it's a common thing. It's actually, it's going to be more that you probably are going to, have that rather than you're not going to have it. And I think that's
exactly.
And the other thing we picked up in the episode with Shelley, around postpartum depression, was almost this need for a proactive referral out. So just for the gynecologist, when you're going through this pregnancy, just saying, please, just schedule an appointment with Samantha Harding, from a physio point of view, just to make sure everything is fine. Just look at, from a
holistic.
From a depression point of view with, Shelley Hall, and there's nothing to say that something's wrong with you, but at least proactively, just look at that, because as you said, now 3 out of 4 women will struggle with this. So maybe just check up on that, and even if you just keep the card or keep the contact details, when you do experience this, then at least you know where to go. And I find that was missing, and I think, again, going through 2 pregnancy experiences with my wife, that was never mentioned. And unless things have changed in the last 9-10 years, it probably is not happening anyway. and then you kind of have to stumble onto this information, which is not easily accessible in Google. So
I think with a breastfeeding mother, you've got hormones that are involved in that. So you've got decreased estrogen levels, which causes vaginal dryness, and you've got increased prolactin levels, which causes low libido. So even just understanding that from a couple's point of view, if your husband realizes it's normal that you are not interested, it's your hormones because you're breastfeeding, that's also, it can make both partners feel better in that understanding. And if the only reason that you're having difficulty with intercourse is because you're not lubricated, then all you needed was a good lube. And sometimes it's a simple fix, but it's just having the knowledge.
No, definitely. And as you said, I mean, the anxiety around that, and also, I mean, the knock-on effects, maybe from a marriage point of view, and just like a feeling of self-worth and all of that stuff must be pretty big. So it's, and again, it's something so small, and yet, if you think about it over years, and it probably is a bigger problem, in terms of marriages and stuff like that. It's just interesting.
Exactly.
So again, just to make the point clear, how would you help a patient with something like that? You mentioned the scarring.
We would do myofascial release of the scar. So if it's an episiotomy scar or a tear, we would manually release it, and we would teach them a massage as well. And sometimes the C-section scar is also quite painful and can also actually be part of why someone is struggling. So certain positions to have intercourse in would put less pressure on a C-section scar. So you could give advice about positions to try. you would work in the pelvic floor muscles as well, just making sure that there's not a trigger point in them. They're muscles, they're just like our shoulders and our neck and our lower back, and we often get trigger points in those muscles. And the reason we get a trigger point is when a muscle's capacity for load has been reached, and it can't take the load anymore, and it goes into spasm. So if you think of the weight of a baby and the trauma of birth, you can understand why you might have some spasm in your pelvic floor. So yeah, we do an internal. It's just one finger, and we would release the muscles inside, and then we can teach some self-release massages and stuff to the mother, and then there's exercises that you can do to stretch out the pelvic floor. So there's fascial connections between big muscles into the pelvic floor, and if you do those stretches, they have an impact. And then breathing, because the diaphragm is the top of the core and the pelvic floor is the bottom. So when you're breathing in and you're taking a nice deep belly breath in, then the diaphragm descends and then the pelvic floor stretches out. So using even breathing to just help you lengthen the pelvic floor. Sometimes we add meditation into it as well, just learning that feeling of lengthening. We sometimes use abdominal ultrasound, where you can see the pelvic floor and they can visually see when they're contracting it and lengthening it. So you want to learn how to be able to relax the pelvic floor to have intercourse, and obviously to contract it for pleasure. But to get that control again is important if you've had a lot of spasm or pain around scar tissue. Acutely, if a person has had an episiotomy, we might recommend something like a sitz bath while it's healing. So like, I think it's a third of a cup of salt and some warm water, and they'll use that. And sometimes we'll use laser or other modalities if they're really struggling. But normally, if you're doing a sitz bath, that helps a lot. And then you can teach them a gentle perineal massage as well that they can do during that healing phase.
Okay, that's amazing. And I'm assuming though it's like also a skill, once they've learned the massage and stuff like that, that's probably useful for the rest of their life. Then it's not just during that time, eh? Yeah.
Yeah. Hopefully if it's a thick scar, it won't give you a problem again. But I mean, a tight pelvic floor can. If we hold our stress quite often in our pelvic floor, and all of our lives are stressed. So sometimes a person has an issue. It's been 3 years and they're fine, and then they've gone through a lot of stress. Maybe they've done something different, like add horse riding or Pilates to their exercise regime, and then it becomes symptomatic again, and then they've got a tool that they can use to manage. So
yeah, I can see how that would be stressful actually. But yeah, so it's actually really cool. I mean, what I like about it is like the lifelong learning part as well, like almost like teaching someone a skill, and when it does happen, then they know what to do or who to speak to. I want to ask you mentioned muscles being in spasm. I've had like sometimes, like in the back as well, sometimes it happens. But is there a way that someone knows that their muscle is in spasm? I suppose the pain would be a clear indicator. Is that the only thing?
Yeah, pain is a sign. I guess a feeling of tightness in an area. If it was not tight before, you might just feel more tight. Obviously in the body generally, if you can push on a knot and you can feel it, it's hard and it's painful. In the pelvic floor, not many people are going to go and look for it. So in the pelvic floor generally, it's just that they're experiencing pain. Sometimes the symptom is that they're struggling to urinate or to pass stool. So to be able to do those things, the pelvic floor needs to lengthen and relax. And it's obviously a very unconscious thing that we do. But if you've suddenly gotten very tight, you might feel like, you can't just sit on the toilet and go. You're really struggling and you're having to strain, and you didn't normally have to do that. So that could be a sign for someone as well.
Okay. Yeah. I mean, like, I think the other thing I learned is the things that you take for granted, even like speaking or eating. I mean, we've been speaking to speech therapists, and they say, how complicated that process is. So, although you said, it should be quite simple, or we don't even take, we just take it for granted. But I think until there's a problem, when there's a problem, then you realize how, how amazing the body is and how complicated, certain things are.
Exactly.
You might like this from a physio point of view. So my brother used to play action cricket,
Okay.
and he hurt the one finger, the little one, and so
Yes.
it can't go fully. And after like 2 or 3 surgeries, it's still the same. But it's amazing how that one finger, and although it's still there, how he can't like pick up weights in a certain way, and it's like it's amazing. Like not having your thumb or something, but yeah, his body is
Yeah,
amazing.
everything has a role, absolutely everything. And the more you learn, the more you realize.
Yeah.
Yeah.
And I suppose that's what's so cool about, like physiotherapists is, I mean, you guys really understand the body, really well. And you keep, like obviously, as you mentioned, with the research and stuff like that, you're constantly like learning more. But it's nice to know that stuff, and see how it all connects up. Was it always been a passion, and especially this area of interest?
I think, yeah, when I started looking to physio to study, I was imagining more sports physio.
Okay.
But then, travel with the sports teams. But as I was studying, I realized that's not where my passion lies. And I only, as a physiotherapist, heard about this field of physio about 4 years into being in private practice. Kind of accidentally while I was on another course sitting next to a legend in this area. And it just piqued my curiosity. And as I said, treating lower backs, the pelvis is also, it's part of our core. It's an important part. You can't just forget about it. So I think I started looking more at the pelvis initially because of back pain and things that I wasn't quite getting right with patients, and this could be the missing link. And then the more I learned, the more I felt sure there's so many women struggling and no one knows that there's this thing that exists, and then I kind of grew quite a passion for it.
I'm glad you did. I mean, one would think as well, based on the numbers and, based on, pregnancy is quite common and stuff like that, that it's, it's a really big, problem, as you mentioned, as well as, I mean, there's a big need. I think that's a bigger thing from a healthcare practitioner point of view, is there's this need and yet no one's addressing it. And no one's talking about it. I mean, that's pretty crazy as well. Yeah.
Yeah, I mean, it is a sensitive topic, and I think South Africans are quite conservative. And if you don't know that it's something that can be a problem or that's normal, you might feel very shy telling someone, I'm actually not able to have sex with my husband since I've given birth, or I went back to exercise now and I'm leaking urine, and I could run before without this. I'm only 29, and this is happening to me. So I think there's a bit of shame, which is sad, that's linked to it. And I guess also maybe you did ask a healthcare provider and they didn't know about physio. Maybe you went to your gynae and they said do Kegels. And while Kegels are good, if you've got a tight pelvic floor and you just keep squeezing it, you're actually going to potentially make more spasm and not help. So it's more about control than just Kegels.
Okay. I've actually heard that before, like the Kegels one. But so would you say there's a need then to almost like educate the referral network, the gynecologists, the GPs, and because I would think even this might be like more mental health stuff, so they would normally go speak to a psychologist first and say, maybe there's something wrong with me. And then maybe the psychologist would refer on. Is there something about that?
Yeah, I think definitely if the person is seeing a psychologist, and psychologists are quite good at asking about sex, they're comfortable talking about it. So then that problem might come out with your psychologist. And if the psychologist knows of pelvic health physio, then they might refer. But yeah, I think definitely there is a need for the specialists and everyone to also learn the value in it and what there is out there. There is obviously one limiting factor in South Africa in general. It's, healthcare costs money. So someone might go to their gynae, talk about the problem, get told they can go to pelvic health physio and just not have the money to be able to afford it. So that is always obviously part of the problem in South African healthcare.
Yeah, I think that goes without saying. I mean, we've been doing a lot of research, around the UK market, from a company point of view. And I mean, like, I think they even, it's like healthcare is not easily accessible. It's the whole NHS system. And, like, you have to go through referrals. And if you don't get the right referral, you're not going to get the right help anyway. So
Yeah.
I think it's probably more a global issue, it seems, unless you really have access to amazing therapists around you that can kind of point you in the right direction. Yeah. And I think with this as well, it'll be interesting to see how the space, evolves and stuff like that. Because just having access to this episode, where someone could have heard a physio, talking about this, that specializes in it, like Samantha, I mean, would already put people probably in a better space, to know. And then what you probably, or where you need to spend the money maybe. Because I think that's the other issue. It's like, yes, it's expensive, but then trying to find the answer is also expensive because you're going through maybe, multiple therapists that have their own view on the world that probably never heard, like, like yourself, 5 years ago, and you would have never, put that together. And yeah, that's pretty amazing as well in terms of thinking about. So in terms of this topic, I mean, and antenatal and postnatal care, is there anything that that comes up that we probably didn't cover so far in terms of problems or what you see from a private practice point of view, or anything around that?
I think maybe the one topic that I didn't cover much is pain with breastfeeding. So a lot of women get cracked nipples and maybe blocked milk ducts, and often the cause behind it is a poor latch with the baby. So and obviously the outcome, if it's not resolved, is often that moms give up on breastfeeding. And there's such good value to being able to breastfeed for the child. So it's sad when that does happen. So the role of a physio in that is we use modalities like laser to on the cracked nipples to help with healing, to get the inflammation down. We do massages to try and help get rid of some of the milk, and if there's a blockage in a milk duct, and we can teach that to the mom. We use ultrasound, and then we also discuss the latching. Sometimes it's easy to fix. Sometimes a woman does need to see a lactation consultant, and then they get referred to a lactation consultant for that. And yeah, then positioning on some ladies only breastfeed in one position, and then you've got milk in some areas that's not being used, and there's engorgement there. And so education on different positioning for breastfeeding as well.
Even that, I mean, I suppose, like, when you're going through your first pregnancy, like, I mean, even like, that's such a, like a, complicated topic, and like it's the first time you've had the baby and you're trying to figure this thing out. But yeah, I did come across the lactation consultant, and I think some midwives do that as well, to help with that. So yeah, very, very interesting, because it's almost the assumption that like women or
It's just natural, hey?
yeah, you would just like it just happens, just had the baby and whoop, like gone.
Yeah, no, when I did training on it, I saw there was a whole day just on breastfeeding, and I was just like, how can it be that complicated that we have to spend a whole 8 hours just on breastfeeding? and yeah, my mind was blown. So well done to any of the ladies who just grasped it, because it isn't as simple as it seems.
Yeah, I must admit exactly that. I mean, like, when I first heard of lactation consultant, again, it was my amateur mind with that. I was like, how could there be a profession around this? And until you realize, like how many babies are born and how many women struggle with this. And, I know when our first child was born, and, I stayed over for the first 3 days or 2 days, maybe, with my wife, to help her. And it was amazing seeing the nurses, how easy they do it. And it was like, like figuring out that swaddle thing. I mean, it was like interesting, hey, as the first parent figuring this stuff out. So yeah, it's very funny, but also it just shows you like what experience can do, like, coming back to topic as well, like finding the right person or the right guide to help you through that stage of your life is like crucial. And if you don't get it right, I mean, there's so many bad things, and impact, that kind of comes from that. In terms of complications, so I think it goes without saying that you do need to find help, and if you can find that, it obviously makes your life better. But if people don't find the right help, have you found some horror stories around that stuff?
I just think a lot of it is sad. Someone who maybe had a mild prolapse after pregnancy, and it was never targeted, because they were obviously by definition not a candidate for surgery at that time, or maybe no one even picked it up. And, then there was maybe not any advice on how changing your posture could help you, or how changing your bowel and bladder habits could help you. And then over time, this prolapse gets worse and worse, and now you needed to have surgery. And sometimes surgery is not always successful, and it comes with its own complications. And then, as I said, a breastfeeding mom who can't breastfeed because it's just too sore. A relationship that gets ruined, a marriage that doesn't make it because you're not able to have sex with your partner. There can be long-standing complications with the diastasis rectus. Some ladies are so ashamed they don't seek help. They just feel so uncomfortable in their own bodies, and that in itself could add to something like depression. It could add to your sexual relationship with your husband as well, if you're feeling so ugly. And so everything can really complicate and cause unnecessary distress and harm to yourself and those around you.
Yeah, the other thing I can't help but think is like how it doesn't get passed even from like mom to daughter, like as in that conversation, because one would think that should be a safe conversation, or maybe like siblings or something. But as you said, it still happens. So obviously women are not seeking out the help, or they don't know. And I wonder if there's an education part, perspective around that. Even maybe to men, to say, actually, this might happen, like maybe you should help your wife through that. Yeah. So, I mean, just from an understanding perspective, I think would be interesting. I mean, I learned a lot through the whole pregnancy part. I mean, and I think the gynecologist joked and he said, if it was up to men would never do this thing. But always hats off to women. Like, if I just look at the changes in the body, like you mentioned, and I think you jokingly said, it just doesn't spring back. And that's true, like your body's changed.
But it doesn't.
Yeah, your body's changed and you have to kind of help it back if if we can actually get back to that level.
Well, I think that is the amazing thing, though, because the body is so dynamic and so plastic, and so quite early on you can get it back, and even later on you can make positive changes. It's not, sometimes people think of things in absolutes, and this is, I'm always going to have pain here, or I'm never going to look like I did before I was pregnant, and that's not true. But no one expects you to be able to know how to get there on your own. You need support, and you need the right kind of knowledge and inputs. But yeah, I think it's lovely and empowering to just know that it's not absolute. This doesn't have to be how it is forever. It can change.
Yeah, and I think everyone always knows the one person that like managed to figure it out, and it was never an issue. It's like baby sleeping through the night. There's always someone that always says like, "Oh no, my baby was like perfect." And they will always just like sleep through the night, and whereas the rest of us
Till number
struggle
2.
through it.
The
Yeah,
second child might not.
yeah, exactly. We actually had a friend where that was actually the case. The first baby was perfect. She like slept through the night and no issues. And I thought, okay, cool, we got this child thing down pat. And the second baby was the complete opposite. Proper problems. I have my last question, and then I think we can wrap up because it's amazing. I mean, we've been talking for close to an hour now, and it's always amazing. When you start the show, I always think, would we have enough to talk about? But it's amazing with every single area of interest how complicated it is, and almost like everyone always says, we can probably talk for probably another hour, just talking about it.
Yeah.
But I want to ask, I mean, for anyone that's interested in this, is there any resources that you would point them to? I mean, are there books? I know you said it's pretty new. Websites or anything like that?
So as a mother, there's a website called Empowered Mother, and it's an Australian website, but you can subscribe to it, and they've got antenatal programs for exercise and postnatal, and they also have a nice program for diastasis. So if you're struggling with that, you can follow their program. It's pelvic health physios that run it. Then there is a book called Sex After Baby that you can buy from Amazon. It's a very thin book. It's meant for a mother who's struggling with it, and it's by Janice Mitchell, who's also a pelvic health physio. And yeah, it shows you some kind of massages for scars, and it explains things, and it might be where you feel comfortable looking into it. You might not be ready to go and see a pelvic health physio yet, might feel a bit scary that someone is going to look there and work there. So this might be where you start. So yeah, those are two that pop up in my mind at the moment.
Okay, cool. I love that, and we'll include the the links to the show notes in the show notes. I mean, on the episode, when we write it up.
Okay.
But and is this like a new discipline as well? Is that something that I need to be like looking out for? Is that because you mentioned now Australia, you mentioned this author, so obviously it's something big, but maybe not that big in South Africa. Is that right?
Yeah, I think it's growing. In physiotherapy, there's still not, you don't specialize in one area. They don't recognize you as a specialist. So it's still a special interest. But if you've done the postgraduate training, there are some people that only work in the pelvis. So they're not going to treat your neck pain, and they're not going to treat your sports injury. They only do this. And we kind of call them pelvic health physiotherapists. Or you have a special interest in pelvic health, but you have to have done specific training to be allowed to work inside the pelvis. It's not part of an undergraduate. So you definitely, to be able to work there, have to have done training, and then you can call yourself a pelvic health physiotherapist.
Okay.
And they don't say women's health. anymore so much, because you can work in the male pelvis as well. So that's why they prefer the term pelvic health.
Okay, cool. That makes sense. Yeah, I suppose it's similar to like, the NDT, trained physios, like working with sensory integration and stuff like that. So I suppose people would be
it's a special interest.
They would be used to the concept. But yeah, that was amazing. We obviously tried to do our best, in terms of preparing for the show. But is there anything that I should have asked you that you thought, would be still interesting to know?
I thought maybe for someone who's thinking about going into the area, it is something that they recommend that you do after you've been a physio maybe for 3 or 4 years, just for the maturity to be able to work with the topic and to be comfortable working in the vagina and those types of things. But I just want to say, think about your space. So some practices have curtains dividing the beds of the physios, and like you really need to have a private space with a door that can close where someone can speak about these sensitive things. And think about the feeling that your room gives to the person. You want them to feel safe and comfortable. So if someone is thinking about going into that field, just think about that. If your space at the moment doesn't allow for it, try to make some plans before you go into the area.
That's such an interesting, important point. I would have never thought of that, but it's like, as you said it makes so much sense. Sometimes you go through these centers and, sometimes you can almost like hear the conversations, outside. And I always think that it can't be good, and, but yeah, what you're saying is absolutely, crucial. I think if you're dealing with those type of those type of patients. But Samantha, thank you so much for doing this. Thank you for discussing the topic with us and definitely bringing your A game.
Thank you very much, Oliver. I appreciate it.
Hey, everyone. Thanks for listening. As always, stay tuned and we'll speak to you in the next episode.